my pleasure to introduce Dr. John Alston today, a distinguished psychiatrist in the field of attachment. We're honored that you've been our psychiatrist here at the Institute for Attachment and Child Development since 1977.
1977 goes back a long time.
So you retired for a while, and then you decided to come out of retirement to work with us. How did you decide to do that?
I've really enjoyed working with these kids. I feel like I've developed somewhat of a unique gift to be able to understand the combination of attachment disorders as well as mixed mood type of disorders. I was asked to return, and it was an offer that I could not refuse.
Can you talk about that history, how it's kind of evolved in your work specifically with the Institute?
Yeah, the Institute really was instrumental in my evolution of my thoughts about these kids. While I have been a consultant to the program since 1977, I was somewhat of an ancillary consultant from 77 until 1991, when I became the exclusive psychiatric consultant to the program and had the capacity to literally see all of the children within the program. So it was at that time that my thoughts about these kids began to develop and change. I initially was seeing many of these kids, as my predecessors did, as having an attention deficit disorder. So I had put almost all of these children on stimulant type of medications, and the result, quite frankly, was rather poor. None of them really seemed to adapt well to that group of medications because they actually do meet diagnostic criterion for attention deficit disorder. It's just that when we put them on stimulants, they do dramatically worse. Because the focus at the moment is on inattention, task completion, low doses of these medications may help in a brief period of time, soon after these kids are put on these medicines, to help them, but as they continue to not do well, the doses are commonly increased, and very often they actually get worse as the medication doses are increased. Similarly with antidepressant medications, we see antidepressant medications either have a profoundly negative effect almost from the very beginning, or we will see a transient improvement over a period of several days to a few to at most several weeks. But as the weeks and months go on, the children actually worsen in their symptoms. And so parents and actually treatment providers actually become of the opinion that these type of medications are not in their, that these children aren't going to respond to any medications. The truth of the matter is they've been put on the wrong, ineffective medications. It's not that no medications are helpful. I actually had one night somewhat of a life-changing dream. I hate to make this mystical, but the dream was a problem-solving dream, in that what kind of parents would do the kinds of things to these children, resulting in severe abuse and neglect. And we'd actually known the characteristics from psychology and other types of criminal type of studies of these parents for decades, but no one had ever put these symptoms of abusive parents into diagnostic criteria. And that's what my dream resulted in, that I began to understand these parents from their own dysfunctional point of view. I began to see that many of them were adolescent parents abusing drugs, running from, at that time, county to county, where law enforcement could not really catch up with them. and began to look at various diagnostic criterion of these parents. These diagnostic criteria primarily focused on mood disorders and that are inheritable, genetic, familial, biochemical. So I began to change my medical treatment plans with results that the children were moderately to substantially improved as a result of the change of medications that I began to prescribe. When we think of these kids as genetically inheriting mood disorders from their abusive birth parents and put them on mood stabilizing type of medications and other medications called atypical antipsychotic medications, it's not that these children are psychotic, they're not hallucinating or delusional, but these medications appear to modify the intensity of their symptoms and result in much more adaptable and agreeable children. I also began to understand more fully the effects that trauma has on these children and added other medications that could modify some of the overall effects of traumas. They clearly have legitimate diagnoses of post-traumatic stress disorder. That's actually what reactive attachment disorder is. Reactive attachment disorder is a post-traumatic stress disorder of infants, toddlers, and young children, secondary to the abuse and neglect that they've experienced. As a result, they become much more emotionally self-protective and not engageable from an attachment point of view. So if we think of this almost exclusively from a post-traumatic stress disorder, again, they fit those criteria. If we put them on medications called anti-depressant medications, again, these children tend to do much worse.
What sort of meds would you put a child on that has RAD and ADD?
Well, first of all, we'd want to understand that the treatment for attention deficit disorder should be the last medications that children are put on, that all of these children could easily be called arousable. Okay? They are high energy, agitated, oppositional, defiant, verbally aggressive, physically assaultive, oppositional, and defiant in their symptom complex. So when we think of those agitated type of children, the last thing in the world that they need are other medications that overly stimulate and intensify the agitation that they already experience. So when we look at their opposition, defiance as a symptom of their biochemical genetic underpinning, and we treat them with mood stabilizing and or atypical antipsychotic medications, the overwhelming majority of these kids become more adaptable, more agreeable, so that it's when we have optimized the benefits of these medications, they then are way more receptive to the psychotherapy in regards to their trauma, where we're actually working with the child, and the child is in a receptive and responsive mood to want to connect with the parents and their therapists, so that it's actually only when continued residual symptoms of inattention, task completion, motivational issues associated with attention deficit disorder, it's only when those continue to be residual symptoms do we actually consider adding a stimulant medication to the recipe of other medications that they're on.
So that comes in last,
yes,
rather than first.
Exactly.
Okay. And I can see how that can be really confusing for parents. If
Well,
they've been
I mean,
told...
sadly, among the things that, I mean, I've had the good fortune to have seen over 3,000 of these children since 1997, the majority of them since 1991. But we're talking about, in over many year period of time, a half a dozen new kids every week. So, and many psychiatrists, even child psychiatrists, don't have that opportunity to see the number of children that I've had the good fortune of seeing. So a lot of this has come by, quite frankly, doing things wrong for the first few years, at least, that I became more intensively involved myself. So it's understandable that psychiatrists or child psychiatrists or pediatricians or family doctors wind up putting these kids on many of the wrong medications.